The evidence base for cognitive behavior therapy, CBT, in the treatment of phobias, OCD and depression is pretty good, and at least as good as that for medication and exercise, which are useful in their own right. The difference from medication being that medication patients tend to continue them for a year or two at least, if the benefits are to continue, whereas the benefits after CBT has ended tend to continue for years afterwards, and if there is a relapse, then brief booster treatment tends to improve patients quickly again. Interest in CCBT developed in the last years of the 1980s and 90s because there had long been increasingly lengthening waiting lists for CBT once its efficacy had been established, and it became obvious that we needed some other way of delivering the therapy, more than just face-to-face therapy, which would take perhaps 10-12 hours of therapist's time. And we found that by using computer-aided therapy, we could cut down the amount of therapist time to a total of maybe 1.5 hours in all, spread out over 10 weeks of therapy. Most of the work being done by the computer, patients finding that they could answer the questions on the computer. And we found that patients usually liked interacting with the computer if the program was a friendly one, which we tried our best to make. And the average reading age that we used was only age 11, so that most people in the community could use these programs. And patients rated these programs as being at least as friendly as the average therapist. There were early attempts at delivering some kind of therapy by computer in the 1960s and 70s. For example, in Madison, Wisconsin, in Dr. Grice's clinic, there was a program to assess suicide risk, which turned out to be an even better predictor than a face-to-face interview with a patient. And people would like being interviewed by the computer because they could go at their own pace with this. And then there were developments with teletext, which we found that patients would like, and with interactive voice response, where the computer was driving telephone responses. And we found that things like PT steps and COPE, PT steps for obsessive compulsive therapy, behavior therapy steps, we got very good results with Dr. Grice and his colleagues in a North American study with over 200 patients in 7 centers. We found the results were as good as, at least as good as, face-to-face therapy. And subsequently we found that with Fear Fighter the results were as good as with face-to-face therapy as well. The idea for Fear Fighter emerged because we had such lengthening waiting lists for patients with panic and phobia and obsessive compulsive disorder. And it seemed the obvious way to go, and computers were steadily improving already by this stage, was to simulate a clinical interview on the computer, ask the kinds of questions a professional would ask in a diagnostic interview in a quick way, and then ensure that the patient had a problem which could improve by the use of CBT. And the prototype, we gradually learned which kinds of questions patient found easy to answer, and it went through a variety of versions until the definitive one, which NICE approved finally in 2006. And this led to its extensive rollout in the National Health Service in England and Wales, and about half the health authorities took out licenses for the use of FearFighter. And we also had licenses for what was called BT Steps, Behavior Therapy Steps, which I developed with Dr. Greist and Dr. Baer in the United States, and we called it OC Fighter, Obsessive Compulsive Fighter, in England. And then these programs were translated into Dutch in the Netherlands, into Danish, and even into Turkish for Turkish speakers in northeast London. In West London, Dr. Stephen Hirsch and I established a computer-aided clinic, a CCBT clinic, to which we got referrals from GPs who were in the area. And the GPs particularly liked referring patients to us because there was no waiting list. Patients could be seen within hours or days. And patients seemed to like this. And also we found that the screening could be done very quickly by a few basic questions. And the main things we needed to screen for was to check that the patients had problems amenable to computer-aided self-help, and that they didn't have any serious suicidal risk. And we incorporated in our programs questions about suicide intent. If that came up as a problem, then patients were asked to immediately discontinue the program and go to see their GP or other human therapist. We found that the results were very encouraging in that clinic. The users liked the programs for the most part, as did the professionals, and they did not think that this posed a threat for them because they had loads of other kinds of clinical problems that they could deal with in the time saved by the CCBT. And we published a paper in the British Journal of Psychiatry highlighting the encouraging findings at the time. The ingredients that the program, the computer program, gives to the patient are the essential principles of therapy and working out how to apply these in practice. Having a brief supporter for a total of about an hour to an hour and a half in all, spread out over, say, 10 weeks. In other words, 5 to 10 minute periods on the phone or by email or face-to-face. Over that period of time, patients valued this enormously. And the usual kinds of questions that might be asked is, I'm just a bit stuck on this particular screen, where do I go next? Oh, just click there in the left-hand corner. Or I'm having problems setting appropriate goals for homework, and then just a very quick answer on that one based on what the patient had entered into the computer. And as regards who can do the support, we found that diverse health professionals who had been through the program, whether it's FearFighter or OC fighter or COPE, provided they'd been through it as a pretend patient from start to end. This would qualify them to act as supporters for the patients. Unless they'd been through the program, they wouldn't know what the questions patient asked referred to. The therapy relationship in CCBT is vicariously with a therapist through the therapist who has provided the program. And patients, when asked to rate the friendliness of the computer program compared to, say, the friendliness of face-to-face therapy, usually rate them as comparable. They seem to like this. And you could say then that there is a relationship, but it needs far less time to develop than in traditional face-to-face therapy. Research has shown that even on the phone, the transaction auditorily, just hearing how the therapist and the patient are doing with one another, is almost as good as having people seeing one another. So it isn't a great disadvantage to have these transactions on the phone, and even email. One can have very good relationships between therapist and patient. Various kinds of technologies now can help patients, for example, SMS, for nudging patients to do their homework at particular times, mobiles with apps, tablets to monitor patients' progress, and we're going to see an increasing number of these technologies that can help patients while they're going about their everyday lives. The Patient Progress Monitoring System, PPMS, is the clinician's window online into the patient's responses, how the patient has been doing, how many sessions, what the outcome ratings might be, and the supporters can have access to this online and base their questions from what they have seen on this online. The PPMS can also be very useful for insurance companies, for the NHS as a whole, as to how patients are doing on quite a wide number of health authorities. We can get national outcome statistics from this too, if used appropriately. The advantages of CCBT for clients is that they can have 24-hour access every day to very efficient and effective self-help at a time of their choosing. Although getting support on the phone may have to be during more restricted hours. The advantage for the clinicians is that this saves them a huge amount of time, say 1 to 1.5 hours over 10 weeks or so, compared to 10, 12 hours in face-to-face therapy. So they can spend much more time with other patients for whom there aren't CCBT programs available. In time, we can expect CCBT programs to become available for an increasing range of clinical problems than there are available at present.